Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we have Professor Hayssam. He is a well-known bariatric surgeon and leader in this bariatric surgery. We can see Professor at all over the world. I can ask. So definite his role, especially for promoting bariatric surgery, education of bariatric surgery. I remember Montreal that time meeting and his live surgery from Beirut. It was amazing, amazing. And that was my first contact with Professor Hayssam. And now I think about 7, 8 years, more than, I think about 1 decade. That was 2013 or yes. And we are in touch. And always when in any meeting, we now, I think dozens of meeting. So we were together, always talk about knowledge, sharing knowledge. And also GLR faculty, one of the, I think, most active faculty member. It's a great honor. Sir, I will not take your time. Please, sir.
Thank you very much, Amran, for your introduction. And thank you for the global laparoscopy and robotics on their continuous work in order to share more knowledge with all over the world in the world of bariatric surgery. So it is very important, really, especially nowadays, in these days where we have this social media and we can actively reach more people to have more presentation like you're doing. Amran, you're doing a great job together with GLR. So I want to congratulate you for that.
Sir, so many thanks. You are really always sportive, encouraging. There is no doubt. As you know, we have completed 4 interview sessions, 4 interview series that each one was for 6 months. And now we have started revisional bariatric surgery. That is one of the important one. This is the time to talk about revisional bariatric surgery, and hope very soon we will be able to make a roadmap, at least guidelines and standardize the revisional. And I will try my best in this session, invite to someone who are expert in revisional bariatric surgery. Sir, personally, I know you, but for my viewers, so especially your experience in revisional bariatric surgery and your brief introduction.
Well, Amran, and I started to do bariatric surgery in the year 2003. And 6 to 7 years afterwards, we started to have the patients who either have weight regain or have complications from their initial bariatric surgery. You know, in that days, it was more the gastric band. So I started to do revisional bariatric surgery in the year 2009, 2010, as I remember. So, and I second your talk about the great need to have the standardization of revisional bariatric surgery, and I will urge from here really all friends to maybe do like we did once for one anastomosis, for other procedures, submit to joining all the big shots in the world and having really standardization for revisional surgery, because it is very important nowadays, especially that now we've been more than 20 years in the era of active bariatric surgery. We start more and more to see these revisions, and it is very important first to know the indications, to know what we should do, and to have a good trained surgeon, not every general surgeon to embark on revisional surgery and having a lot of problems.
Sir, excellent. Sir, as we hear more about now in future, definite we will hear more about revisional surgery, but the terminology that in different international conferences, so someone asked, so this is revisional, conversion, correction, how you define?
Well, this is a good question, Amran, and there is, not to my knowledge at least, there is a clear terminology for that. But I will tell you from my humble experience, all cases when we revise patients with bariatric procedures are revisions. Now you are going to call it correction if you are correcting a roux en O to roux en Y, if you are doing a conversion of band to sleeve. So, but I believe all of it will go under the big name of revisional bariatric surgery. So if you go to correct a hiatus hernia after sleeve, this is a revisional surgery. If you go to correct a band to mini bypass. This is revisional, but it is a conversion of band to mini bypass. So not to get really lost in the terminology that is not really clear, I think we can call it all revisions, and then case by case, you can call corrective, you can call conversion, or whatever the case it is.
Excellent, excellent. And again, another terminology, that is failure of bariatric surgery. Sometimes we know some definition, and this definition is according to a bariatric surgeon. Sometimes this definition is from the patient view. So how you
Yeah.
can highlight this, and how can especially public awareness, and how can we talk with the patient so then we can hear less about failure of bariatric surgery?
First, Amran, and I disagree completely with the term of failure. Yani when you treat, we all know that obesity is a chronic problem,
Yes.
is a chronic disease. So when you're dealing with diabetes and the diabetes did not resolve, this is not failure of the treatment. When you're dealing with cancer and the cancer recur, this is not a failure of the treatment. The disease per se follow-up may oblige you to go again into medical, surgical, endoscopic treatment, okay? But this is not a failure. But if you just want to tell me what is, I mean, weight regain or the way that is not really called a success of bariatric surgery, but not failure. I believe that having, you know, the international criteria is to talk about more than 50% excess weight loss or more than 30% total body weight loss. But again, failure should not be in our term. And when we talk with our patient, this is weight recurrence. Okay, this is not a failure of the treatment.
Sure, sure. Sir, again, sometime, because personally I can see here in Dubai, unfortunately, our colleagues or myself also, sometimes to attract the patient, we promise big things. Yes, you will lose like this will be happen, there will be no diabetes. And maybe due to our, so this conversation, so expectation of patients is something that is not reality. So we must be realistic.
I totally agree. It is really from the first, when you sit first with the patient, it is very important to give him something that is really realistic, not just to catch a patient to operate on him and afterwards he will come to you, well, doctor, you promised me to that I will not have diabetes. You promised me to have 100% excess weight loss. So it is very important to be clear with the patient. And I think another definition of success of bariatric surgery, Amran, is not just the numbers. It is really what the patient is feeling in his journey towards losing weight. I mean, sometimes you will have an excellent numbers. Patients with a BMI of 25, but he is not satisfied. I cannot call this success of our bariatric surgery. It is very important to see how is the lifestyle of the patient is continuing after our bariatric procedures. So this is why we come from the era where a lot of sleeve surgery is done worldwide and a lot of newcomers who wants to give the best result to the patient and they go into severe restriction. And we are seeing catastrophes. You are seeing excellent numbers in terms of excess weight, but the patient cannot eat. Patient eat and vomit. Patient have severe reflux. Patient is malnourished. And same for other procedures, but more with the sleeve because it is the most of the procedures nowadays are sleeve gastrectomy. So it is very important to know how is the lifestyle of the patient going other than just giving number. Patient is not a number. It is a whole life. Is he happy with your surgery or not? If he is not happy and you have good numbers, this is not a success of our bariatric surgery.
Sir, excellent, excellent. Why I am asking these basic questions? Because we have a lot of youngsters and they are now, because GLR, main our platform is for youngsters. And also this message, sharing knowledge. So due to this, so a role of MDT, and also then how you deal with the patient, how you convey your message, that is as you have mentioned, so that the satisfaction of the patient, results of the patient, that are more important. Excellent, sir.
Definitely.
Sir, so this revisional bariatric surgery, as you know, much better than me, is not initial surgery. That you think when you scope, so then there is different scenario. So what is what, this is my question? Technical consideration. So you are dealing with the thick tissue. You are dealing with lot of adhesions. We are interested to highlight this point. This so when you are going to do so, what you can face inside the abdomen.
It is very important, Amran, to know what was done before if you can. Yani either having an operative report or to contact the surgeon who did the first surgery. لأنه, as you know, we went into sometimes really an abdomen and we don't know what was done, especially in the era of يعني, the surgeries. I mean, you go into a room why you don't know what is the BP limb. You go into a vertical banded gastroplasty, which is even more catastrophic. 10 or 11 techniques of vertical gastroplasty. So first thing is to know what the patient had as initial procedure. Second, to see if the patient really is he cooperative enough to continue. And sometimes patient just need a solution and he put you in the corner and just to operate on him. It is very important to have this MDT who will approach the patient psychologically from a nutritional perspective to see really if this patient is really fit to do a revisional bariatric procedure. It is not just patient come with weight regain, he wants to do the surgery, okay, let's go and do the laparoscopy. So, I mean, it is a full preparation that starts from the discussion with the patient to know what he has initially. And then I prefer always to have a scope to see the stomach, how it looks like, whether we have hiatus hernia, whether we have esophagitis, whether we have any problems in the stomach also before giving the final decision. And after I do all my investigations, still, I tell the patient I cannot make a clear decision until I go in, because sometimes you see something that is not really what you thought it is. So it is very important that the patient should sign a consent that may go for sleeve or a bypass or a mini bypass or an wide gastric bypass, not to be stick with one procedure, and you may change your decision intraoperatively.
Sir, excellent. So according to this question, especially the message is so first we must know about the patient with previous report. If possible, we must contact his previous or her previous surgeon, and we till we can do so. We must be eye open and also cost effective, as because especially my target is those countries there is some limitations, but scope is very important to do. Must know, at least must know what we maybe face, then go for a surgery. Sir, some technical points as well. So we are interested. So just your entry, so because this patient is revisional surgery, definite first entry is very important, dissection, and also if we can take support or help from another our colleague in such a situation, because this message is especially for our youngsters, which center they can do, and it's better to go to a senior person. So please, sir, highlight these points.
And I always advise my fellows who graduated from our programs to work in a couple. لأنه especially in bariatric surgery, when you will start, you need another eye with you, you need sometimes another hand, you need another nerves. Sometimes you don't have nerves, especially in these revisions or complicated cases. So it is not, my advice really is not just to jump, especially on patients with revision, unless you are really supported either by a good hospital, good multidisciplinary team, and another mentor surgeon in the team. لأنه you will never know when you will have a problem in the operating room and you cannot handle it and you need an assistance. So it is very important to have to work these cases not in a small hospital, in private hospitals. It should be in government, in university hospitals, or where you have a center for excellence, or you have a good support from good bariatric surgeons and multidisciplinary team.
Sir, so much thanks. Sir, now I present a case, a patient after 8 months, 9 months after a sleeve gastrectomy from another center consulted to you, and definitely you have faced many patients, such a patients with inadequate weight loss, just 30 to 40% excess body weight loss, 30%. And the first 5, 6 months, okay, then she or he started to gain weight just with first 9 months. And when you evaluate and you did scope or you did barium, yes, there was a fundus there and also dilated sleeve that was not till standard sleeve. What you will do in this case? So if I can question, so we will wait till 1.5 years and we will start medication. Second one, we will access for endoscopic help, or no, we will go for surgery. Sir, please.
I don't think the time is the my landmark for going into revisional bariatric surgery or not. Now, sometimes you will have a very early failure, especially as you know, we are in the field, and we know that there is a lot of surgeons without a minimal experience in bariatric surgery are doing bariatric surgery, and we've seen really catastrophes in the shape of sleeves where the fundus is completely there, where there is no dissection of the short gastric vessels sometimes. So I don't think it really makes sense to leave the patient just to suffer for another 1 year, go for diet and whatever suboptimal treatment. I think once the indication is there, patient fit into the indication, we should go regardless of the time. I will not wait for 1.5 years for such a patient. I will go in, and my first approach for patients with failed sleeve is the one anastomosis gastric bypass, unless the patient is having severe reflux or grade B esophagitis. Even if the sleeve is not really, unless I'm having a big fundus left, I may go for re-sleeve when we have, by CT volumetry more than 300 cc's of as a volume capacity. Then it may be indicated, but I never remember that I have done a re-sleeve on patients who had initially a sleeve. I prefer to go either for a mini ROY, and sometimes you'll be amazed now, I do plication for patients with BMI between below 35.
Okay. So with the plication, you reduce the size of a sleeve.
Yeah.
And then we can do so OAGB or any surgery that is the physical
Exactly.
complication.
Even my technique in one anastomosis after a sleeve is I don't cut the stomach. No. In my early experience, Amran, I remember very well in the years 2012, 2013, I operated several sleeve to mini bypasses. I have really two bad leaks. I used to do sleeve, I re-sleeve the sleeve, and I do a mini bypass. And I have two leaks that last for 6 to 9 months. And after that experience, I started to do, I know it is important to have restriction in the one anastomosis, but it is not really mandatory to have severe restriction. So I play it safe. I do a plication of the sleeve, okay, a good plication, and I do my bypass at the pyloric antrum. So I didn't have really any problems converting sleeves to mini bypass and doing this technique.
And then, sir, you also staple this antrum.
Definitely.
Ah,
I cut at the antrum, and then I do the
this will be one
anastomosis, and do
definitely.
afterward the
Otherwise,
plication.
it will be sassy. I agree with you. Sir, regarding BPM, because we have started to talk about change of sleeve to one anastomosis, what is your protocol? Are you measure whole length, and what is the standard? Just imagine patient BMI is again 40, 45. So from he reached till 28, 29, and now gain weight now after 6, 7 years of sleeve gastrectomy.
I think this is very important also, Amran, to know and to give you my experience in that regards. لأنه I have a lot of patients who for whom I did sleeve to many bypass and they did not lose weight as much as we would love the patient to go. Between 2012 and 2019, I used to do 2 meters to all revisional cases, and I have at least 20% of either unsatisfactory results or weight regain. And the year 2018 or 19, I started to do one third, two third. So I measured the total small bowel length, and I take one third as a BP limb and two third as a total as
Common
alimentary
channel.
limb, common channel. And since then, really, I have a completely different results, excellent results so far. I'm collecting the data. I'm not did not publish yet, because I'm working on that. I have really nice results by using one third, two third, and I didn't have any malnutrition in these patients.
Sir, have you faced in these cases steatorrhea or loose motions?
There is some steatorrhea that decrease with time, and steatorrhea you can see it in the primary one anastomosis or in the conversion of sleep to mini to one anastomosis. The key here is to give the patient strict dietary restrictions on sugar and carbs. لأنه with these he will have more steatorrhea. But I did not really need to revert any of my patients, although from the old one anastomosis patients, when I used to do to 200, 250, 2 years ago, I have several, at least 6 or 7 patients that I reversed because of malnutrition. I have one case of hepatic failure also. This was like 5 years ago in 2016. We used to do 250, 300 without measuring the total small bowel length. And after the standardization of one anastomosis, I think we're having less and less problems, especially after the good work of Jean-Marc Chevalier, of Kamal Mahawar, all of our friends who publish on the necessity of having a BP limb length that is not beyond 180 centimeters.
But sir, practically, so that I also talk with Chevalier, also talk a lot with Kamal. They are very conservative. So 150, 180, but practically that, as you have mentioned, personally also I see here in Dubai as well. So when 180, so patient don't lose weight. This is also another issue. I am talking about revisional.
In revision, and definitely I disagree. No, from my personal experience, humble personal experience, we have non-satisfactory weight loss in at least 20 to 30% of our patients. So it is not enough to go for 150, 180 in revisional surgery. I totally agree. But I'm talking about the primary. In primary, I agree with the Kamal, Jean-Marc, or the others who said that 150, 180 is good, unless you want to do a total small bowel length measurement. Then okay, you can go more. But still till now, it is not the standard of care. And after the consensus meeting of one anastomosis, still we are doing 150, 180. And for the revisions, I think it is very important to go for one third, two third.
Sir, another issue that we routinely see after a sleeve gastrectomy is GERD. And there is really also, it is a challenge, and sleeve is good surgery. Personal, so my number is low because my main practice is the one anastomosis gastric bypass nowadays. But overall, good surgery, common surgery, and we also know the main reason of GERD is the patient selection. So when you will not select proper patient and some technical issue. We are not talking about how we prevent GERD because we talk a lot during our interview session of safe sleep. But my now, if patient is suffering with intractable GERD, patient is smoker, what you will do?
Okay, well, first, I'm not a sleeve fan, but in my practice, I'm doing at least 30% of my practice is sleeve. But let us agree, Amran, on the issue of GERD and reflux is a built-in into the obese patients. We know that if you scope 100 obese, you will have Barrett's, you will have grade B esophagitis, you will have grade C, even if they did not undergo any bariatric surgery. So this is why if you look into the literature, you will find, I agree that sleeve, maybe it is more refluxogenic than the others. But if you look at the one anastomosis gastric bypass, and for the Roux-en-Y gastric bypass, which you consider as a treatment for reflux, you will find 20, 30% erosive esophagitis in both bypasses after 5 or 10 years. So we should know that by default, our patient is a reflux candidate with time. And we should tell him that you may have this reflux. You should pay this this problem of reflux. If you want to lose weight, you have chance 20, 30% of having weight, whatever you are going to have, sleeve bypass or Roux-en-Y gastric bypass. But for the patients who are operated and have reflux esophagitis, for patients with grade B or grade C, I would go for a Roux-en-Y gastric bypass definitely. This is the data from all what we see worldwide. For patients with mild to moderate reflux, grade A esophagitis or gastritis, the data is promising for one anastomosis gastric bypass. And my humble personal experience, I have a lot of improvement and for the patients with the reflux. And the problem of reflux, especially in sleeve, is mainly the high pressure. And whatever you are going to do to relieve this high pressure, patient will improve with time. But again, we know that we are sometimes in the corner for patients with Roux-en-Y gastric bypass with severe reflux. So this is also a problem. So going by, from sleeve, which is a good procedure, if patients have reflux, to go for maybe one anastomosis, still you may have a chance to do Roux-en-Y later in life. I think this is something that we always should think about before embarking right away to the Roux-en-Y gastric bypass, unless it is clearly indicated.
Sir, definitely. So I will also explain about more about this case. So patient, there is some migration, definite, we will reduce that migration, we will repair that hiatal hernia or hiatus. But patient is a heavy smoker and maybe he will continue to smoke. And if we will go for any type of gastrojejunostomy, more chance of marginal ulcer. What is your opinion about truncal vagotomy?
I saw some centers who do the truncal vagotomy, but still it is not. It did not show really a great improvement. They need some more numbers to see their outcome. The ideal is to try to push. Although I know it is very difficult for our patients. And they will promise you, yes, doctor, and I will stop smoking, and you will find him smoking maybe in the hospital. And it is very important to put the patient under his responsibility. You will tell him, listen, Anna, I'm not with you at home. If you want to injure yourself, it is not my problem. I'm trying to help you. The best for you is to go for a simple bypass. I don't want to add any procedure without really good studies in it, adding truncal vagotomy. So if the patient responds, it's okay. And from my patients, and I've done more than 1,500 cases of anastomosis, I have 2 perforations from heavy smokers, and they cannot stop smoking. And what we can do as surgeons, we can give advices, doing follow-ups, but you cannot put the patient in a prison not to smoke. Patient should be also responsible as much as we are responsible. So again, not to put us in a corner where we should add a procedure because the patient is not compliant. I believe that it's very important to have this relationship between patient and surgeon, and the patient should be responsible for the procedure he had. This is my opinion, and I don't do truncal vagotomy. I saw some reports, promising report, but we need some time, more time. I will push more for a good follow-up with the patient, and for those who are smoker, to do serial endoscopies every 3 to 6 months to follow if they have ulcers, to treat, to try to convince more patients not to go for smoking.
Sir, excellent. Sir, we have a question from Egypt, I think, our colleague, and he's asking, because we are live also. on Facebook his question about Roux-en-Y gastric bypass after a sleep. If you are doing Roux-en-Y gastric bypass due to GERD, definitely maybe patient BMI is in normal range. At that time, what will be your BP limb? And if weight gain, and you are going to, or you prefer Roux-en-Y after weight gain? These are two questions from the our end about BP limb also in Roux-en-Y.
Okay, for the BPLM, for Roux-en-Y, for reflux patients, I will not go more than 50 for the BP and 100 for the alimentary. For weight regain, definitely, I'm not of those surgeons who prefer to do Roux-en-Y because I believe that Roux-en-Y is a kind of restrictive procedure like the sleeve, unless with the new definitions, with the new changing in the technique by the surgeons who are doing Roux-en-Y, where they go for 100, 150, sometimes BP limb length, and they are measuring the total small bowel. And then it is, and we have BP limb like the one anastomosis or any gastrojejunostomy. So personally, and I think, for patients with reflux, I would second doing severe reflux, BP limb length of 50 with 100 alimentary. For patients for weight regain, I personally don't advise the Roux-en-Y gastric bypass. Okay, I'm clear. The reason why is always I'm thinking about my patient. If especially most of our patients are between the age of 25 and 40, he will need something else later in his life. So once you are stuck with the Roux-en-Y gastric bypass, you can do something, but it is not really easy, and the results are not as good. So let's go by. I will offer him, if he failed his sleep, I will offer him a one anastomosis. If not, then I will distalize more either by Roux-en-Y or another one anastomosis. But not, I will not go from sleeve to Roux-en-Y for weight regain, especially if you look at the data. A lot of studies showed, and the most famous and the good one is the one of Scott Shikura. And his conclusion was Roux-en-Y gastric bypass is good for reflux and not for weight regain. The original one, okay, the original
Yeah,
Roux-en-Y. I'm not talking about
understand.
having a longer BP length.
Yeah. Thank you, sir. Sir, another so case, because this is the time, best time in my, and this is the difference from a webinar. Because in webinar, so a surgeon like you, so only a 5 minute, 10 minute, but now we have sufficient time, and this hunger and thirst of questions, so we can ask questions. Sir, a case after weight regain, after sleeve that is a real case. After a sleeve gastrectomy, weight regain, but there is no gain, not yes, endoscopy, okay, there was not such a, as a mild, yes, but not severe as a phagitis. We have two options. Patient is smoker, unfortunately. We have two options in this case. We can go for one anastomosis, gastric bypass, or SADI. Because when we will do SADI, that this will be jejunostomy or ileostomy, and surgeon can do. His expertise is okay. What is your opinion about SADI and one anastomosis? Because in one anastomosis, we have, as you have mentioned earlier, so you face two perforation after one anastomosis.
This is a tough question to answer. SADI definitely is a good operation, and SADI, when it was introduced by our friend, really there was some resistance on it, but it gets acceptance. First, I think in the US, because the one anastomosis was banned over there. For me, I will tell you my not experience, my personal opinion. Anna, why to do anastomosis at the level of the duodenum when you can do an anastomosis at the level of the pyloric antrum, like one anastomosis? Complications are more. The leaks are duodenal leaks. The dissection at the gastroduodenal area is not easy, especially for the youngster. So the issue of success of bariatric procedure, it's not just that it is effective. It is how it is reproducible and how it is easy and how to handle its complications. Second, in SADI, we go for 350 sometimes they go from the ileocecal valve and they count 2 meters. So sometimes you have 350, 400 BP limb length. Still, we should wait for the long-term results of nutritional deficiencies in SADI. So I don't really think that leaving that part of the duodenum will make a big difference when you weigh the risk benefit of doing SADI versus simpler procedure like the one anastomosis. This is my personal opinion on this.
Thank you, sir. Sir, in previous session, not now, one of our colleague asked question about so fundoplicated sleeve patient. They did fundoplicated sleeve, and after 4 year, 5 year, now patient consulted with weight regain, and you have decided there is everything is okay, no esophagitis, no GERD symptoms. You are decided to go for one anastomosis gastric bypass. So you will touch to this fundoplication or not?
I have a few patients, and I cannot talk about big experience, but I operated at least 4 or 5 patients with previous fundoplication, and the fundoplication was working beautifully. So really, I did not touch. I just leave the fundoplication as is, and I do my transection below it, and I do an anastomosis as usual. لأنه sometimes going in that area and deplicating the fundoplication with the risk to have either gastric perforation or sometimes esophageal perforation. And what's the benefit of having this is to have more restriction. It is not really, I think, very important. So on my personal approach, unless the wrap is completely the fundoplication is not there, maybe I will do it. But if not, the wrap is in place and patient is asymptomatic, definitely I will not touch it.
Sir, because I know you are also doing gastric plication, and maybe you have faced, because I know one of colleague in Lebanon, he's doing frequently gastric, until this time he is doing gastric plication. Have you, definitely you have faced, personally also, many times I have faced, because I was doing also gastric plication. What you will do in these cases? So there is a dilated pouch, patient weight regain. Now you have decided to go for one anastomosis. Are you open the flap and you do standard sleeve, and what you do, but how you deal in these cases, weight regain or gastric plication?
Well, first for the plication, let's talk a bit about it, Amran. When Muhammad Talibur started to do it in the years 2004, 5, and 6, a lot of, like what we have in another procedure, like the one anastomosis, a lot of objection, why to do it, it is a bad procedure. But after 20 years, you are seeing now, maybe it will be the best procedure after 3 to 5 years, which is the endoscopic plication.
Yeah.
So they are convincing us now that endoscopic plication is a perfect procedure, but gastric plication endoscopic is not good. Okay, so you can feel the instrumentation of the surgeons by medical companies sometimes, and we should try really to stay away from it. I'm not against endoscopic gastroplasty. Okay, it is a very good procedure, but I'm against those who will, when you talk about plication, no, it is not good, it is bad procedure, and they are going, they run to learn how to do the endoscopic gastroplasty because it is sometimes more beneficial for them in terms of marketing, I mean. So this is why I'm doing gastric plication since 2006 or 7. I think doing it in the good indication is very helpful. You cannot do it for the super obese patients. It is ideal for the patients with BMI 35, between 30 35 with comorbidity. We are in the countries where sometimes patients cannot pay a penny for his surgery, Amran. And we need to do sometimes some compromise. It is not a compromise because now endoscopic gastroplasty is accredited, okay? So to do gastric plication, laparoscopy in a good way, it is much, we know, we are surgeons and we know laparoscopic gastric plication, you can do it beautifully, much more than doing it endoscopically, okay? So first, I think there is a place for gastric plication, okay, for patients with borderline BMI, for revisions, for patients after sleeve with not BMI of 40 or of 50. So when you go into these indications, really you will have a good results. Now, what I'm doing for the failed plication, there is two types of failed plication. The first type where there is an expert doctor like you mentioned, Dr. Andraus, who are doing plication in Lebanon. You will see a perfect plication, very nice, but with weight regain. You cannot deplicate and you cannot sleeve, definitely. لأنه the plication will be too close to your staple and you will go into catastrophes. So what I'm doing for these patients, I redo the plication and I will add malabsorption, whatever you want to do. Okay, so you can redo the plication again. Do go for the pouch will be a bit dilated. So I will redo the plication and I do one anastomosis, or I just redo the plication if patients had borderline morbid obesity with BMI around 35.
Sir, excellent. Sir, I have added loop enterohysterectomy since 2016. And now I did hundreds of cases, application with this. And also named by Professor Galva. I remember we were sitting in Antalya before COVID-19 and I showed him the video. So I am doing this surgery for my diabetic patient in low BMI. Low BMI, I mean, because in Dubai we can do 30 to 40, 30 plus. Below 30 we cannot do. So I am doing this and he was interested. Oh, what are you doing? So at that time, so the name was, so I asked, so this is a application plus this loop urban anastomosis. He asked, no, ask this step-less SASI, because already people know SASI and it is easy to convince them. Yes, when you will ask plication, so there is some resistance against plication and amazing result, sir. Now I did hundreds of cases and you can't believe no weight regain till this time. I have started in Pakistan routinely. I am doing that. You highlighted cost effectiveness, definite. I have lot of patients, they cannot pay, diabetic patients, BMI 36, 37, 38, like it. And then add, it depends on the BMI of the patient, 200 from DJ, no need to go for an ileocecal. So this is like Saj, we can ask her. I have no idea. There are different names. So, but we do this and there is no stapler. And one thing that also now I think near to 100 cases I did, the BMI is 40, 40 near to 40, 40 plus plication that I add 200. And then also I plicate near this pylorus, little dissection completely. And after that, I did barium. There is no barium, goes to duodenum, no stapler, nothing. Now I have about 100 cases and I will publish soon the data. That is amazing results. No stapler, nothing. But it take time, little tricky. So definitely we prefer, and always I use Prolin, as you know better than me. That is a excellent results. Agree with you, sir. Sir, any comment about this?
No, I totally agree, Amran. You know, in our country, in Lebanon, we call the doctor, we call it Hakim, the wise,
Yeah.
the wise man. لأنه sometimes you know that statisticulation, we call it statisticulation or playing with the statistics that are sometimes manipulated by with my respect sometimes to companies, we are the one who should decide whether we should do or not, and we know better what is good for our patients and to our community. So what applies to the United States sometimes does not apply to Lebanon or Pakistan or any place else. So we should, from our expertise, try to still stick to the standard of care as much as we can, but sometimes to offer to our patients something that between brackets maybe the Western or the US will not accept it. Okay, but I allow myself to do this, like the plication we're talking about. Till now, it is not accredited worldwide as a laparoscopic plication, but it is accredited as endoscopic gastroplasty, which is weird for me. Okay, yeah. So I think we should be wise in our decisions and our approach to our patients and what to choose to our patients, especially in our countries.
Sir, so much thanks, sir. And now we will talk little about intractable marginal ulcers after Roux-en-Y gastric bypass and anastomosis. You highlighted your two cases, perforation in OAGB, and both of those cases were smoker. So in such a case, what you do and what was your experience? What you did in those cases?
Well, you will see, and I did not convert to Roux-en-Y. I put a feeding tube inside, so drain the ulcer outside, and put the patient on strict. I tell them if you will have more smoking, you will have another perforation. So fortunately enough, the phone did not ring till now. So what I did, just I put inside it a Foley catheter, okay, and I injected the balloon with water and take it outside and put the patient in rest for 2 or 3 days, and both of these patients work.
Sir, can you repair that? And we can repair that.
It is impossible to repair. The tissue is too friable to repair. You cannot put a stitch either. If you know patients were septic, okay, I did not want to go for a major Roux-en-Y in these patients, so I tried to do a salvage procedure. So just drain the ulcer outside, and fortunately, both of patients work with this treatment. But another option is to go for a Roux-en-Y with resection of the whole component.
Sir, another same. So, but these both cases were peritonitis and perforated marginal ulcer. If only marginal ulcer, but that is intractable marginal ulcer. I am talking about anastomosis gastric bypass. As you know better than me, so this bile is buffering effect, and overall we see less case of marginal ulcer in anastomosis as compared to Roux-en-Y. Till in Roux-en-Y pouch is shorter, less acid production. In OAGB, more acid production, but due to bile buffering effect, maybe this is our thinking. I have no hypothesis, but practically we face less. But sometimes we face intractable patient is not smoker, but intractable marginal ulcer, no response to medication. Have you faced such a situation? And in such situation,
I face it, as I remember, twice. And I have to do, and it was really a super tough surgery. You cannot, the stapler, when you want to put it above the ulcer and to cut, you will not find really a super thick stapler sometimes to cut it. It is very hard tissues. So I try to go as much as high as I can to feel safe to put my GIA above. And I converted the mini bypass to one anastomosis. I have two cases that I converted from one anastomosis to Roux-en-Y because of nearly perforated marginal ulcer. It was not perforated, but severe marginal ulcers. But the issue of having more marginal ulcers than the Roux-en-Y, really the data didn't show that it is really that statistically significant in terms of ulcers. But there is, in Roux-en-Y gastric bypass, there is I think a Brazilian study that showed that whenever you will have a more than 30 cc's pouch, your rate of ulcer will double.
Sir, we cannot, I think we lost your video and also voice. Professor, can you hear me? Just we were talking about intractable marginal ulcer after one anastomosis gastric bypass. This was our topic, and I think we lost Professor. But I will try my best to, hopefully he will join soon. So we were talking about this. If you, my viewers, if you have any question regarding marginal ulcer, because this is the main issue of after any type of gastric bypass, gastrojejunostomy or gastroileostomy, and this is the hard talk. So in such a situation, especially when patient is a smoker, and so weight regain after a sleeve gastrectomy, when there is a patient is smoker as well, and weight regain after a sleeve gastrectomy, and also there is no such symptomatic and as well as endoscopic GERD or esophagitis, what you will do in such a situation? Because if you will go for anastomosis gastric bypass, so there is chance of marginal ulcer because patient is smoker. And can we go for SADI in such a situation? This is, I think, hopefully in near future, we will able to finalize such a, sir, please.
Yeah.
Just we were talking about marginal ulcer.
Yeah. You heard my answer?
Yeah. Sir, I think there was some issue connection. So if it's possible, you can explain it.
I said that I have two patients. They have a deep ulcer after one anastomosis, and I did for them room gastric bypass, but it is not really easy. It is one of the most difficult cases I've done because the inflammatory reaction will go up, and it will be difficult to see an area of the stomach where you can put your stapler safely. So I need to really go up to transect the whole component of the ulcer with the anastomosis, and I did a room gastric bypass. But what I was saying, Amran, the rate, I believe, of marginal ulcers and the one anastomosis, it is almost equal to the ulcers with the room gastric bypass. And this will be proven, I think, with time. There was one Brazilian study that showed that for patients with the room gastric bypass, the size of this pouch, whenever it is more than 30 cc's, you will have like double incidence of anastomotic ulcers. I think this will not apply to an anastomosis because the configuration is different. But we need more studies from our colleagues to collect the data to see what is really the real marginal ulcers after one anastomosis.
Sure, sir. Sir, another, so this is also because definite these are real cases. So we sometimes we face intractable marginal ulcer in Roux gastric bypass. Have you faced in such a situation? And if you faced, it was necessary to go any surgical intervention in your experience?
I didn't personally have patients with intractable ulcer post-room gastric bypass. But I think the approach will be the same. We should resect the whole ulcer and redo the configuration again if you face it. It will not be different from the one anastomosis.
Yeah. Sir, earlier you have mentioned about severe weight loss or malnutrition after one anastomosis gastric bypass. We are interested to highlight more about such a case. What do you do?
I will tell you a few of my cases that I've done personally, or they were referred to me with the severe malnutrition. The first one, and I did not see her. It was an Iraqi patient with a BMI of 80, and I did for her one anastomosis gastric bypass, and she went to Iraq. And after 2 years, they called me and that she had hepatic failure and she passed over there. From my patients that I followed in Lebanon, I have one patient who have severe hepatic failure also. But all of these patients were in the era where we do 250 without measuring the total small bowel length since 2018, when I started to do 150, 180, 200 with total small bowel length measurement. I didn't have any issues of malnutrition. But I have a lot of patients, at least 4 or 5 patients who were referred to me after SASI, okay, with BMI of 20, with an albumin of 2. So these are really patients that need an extra effort to get them out of their problems. You need a center where you have a good nutrition, a good TPN. I put for one of them feeding jejunostomy before going into the corrective surgery. So it is very important to reach an albumin of at least 3, and you make sure that his nutritional status is good before going into corrective surgery. So I have a few patients with SASIs that are referred to me, and this is the importance, Amran, a message that we send for our colleagues and our youngsters. The issue of BP limb length is not a joke. And whenever you are going to go beyond 200 meters, my advice is to have a total small bowel length measurement. لأنه we know that 10-15% of the population will have maybe 4 meters of small bowel. So when you do 250, patient will have problems.
Yeah.
Especially sometimes patients are not really cannot buy proteins and take I don't know, meat and whatever. It is important to having a high protein diet. So really to stick to 150 or 180 for the BMI of 40 female and male for the primary one anastomosis, or SADI, SASI, whatever you want to call it, is very important. Or you do your total small bowel length and you keep at least 2/3 of common channel.
Sir, really excellent message, especially in our countries, especially there. So yes, in Dubai, I have no issue for TPN, fortunately. But sometimes we have patients, they are not covered with insurance. Again, there is an issue. But this, so we must prepare the patient, and we can do feeding tube jejunostomy. We can prepare the patient and resuscitate the patient. Then we can go for another laparoscopy, no issue, but patient will be in safe zone. Sir, my question regarding your patient, because this is very important, that patient 80 BMI. So when you did scope, you remember there was NASH, NAFLD, yes, there was definite fatty liver. But have you seen any think maybe this is cirrhosis or advanced NASH, or you don't remember about this?
No, there was no cirrhosis. It was severe steatohepatitis. We can see it clearly, but there was no any signs of cirrhosis. But you know that these patients sometimes are on the borderline, and they need some push to go into the complete decompensation of their hepatic function. But what is weird, and you know, this happened to her 1.5 years after her surgery. So really, it was not really clear to me. But I talked to her gastroenterologist in Iraq, and he told me that she came with elevated LFTs, with a complete fulminant hepatic failure, 1.5 years after the one anastomosis.
Sir, can we take message? Because this is also, again, I am asking, this platform is also, we all are learner and student of bariatric surgery in such a situation. So we can go stepped surgery. So we can take two message. One, close follow-up, especially for our youngsters if they are doing any type of malabsorptive surgery, because especially in Pakistan, when patient goes to villages, so they left, though they think surgery and finish, then there is no contact with the doctor, unfortunately. So if you are going to do such a because this mini is name is mini, that is not mini, that is a huge malabsorptive surgery. And we again, sir, really you can't believe here in Dubai I am facing. So patient asked me, we need Taghir Masar, but mini. So Baba, this is not mini. We don't need that gas mede. We don't need that actual Taghir Masar that ask Ruan why. So this is a mini. So Baba, this is not mini. This is more aggressive. So we can take two.
Yeah,
Yeah, please, sir.
yeah, I agree. I agree. It is, I think, a misnomer to call it mini gastric bypass. With our respect to the creator, Professor Rutledge, we keep it as mini. And I'm talking more and more about what one anastomosis gastric bypass. And for the advice, I think, let them learn from our mistakes. When we started to do the one anastomosis, there was not really a full standardization worldwide about it. And now there is some standardization. Don't try to offer more for your patient and you want him to lose more weight and you get him into troubles and patient may die. So we can accept weight regain, we can accept non-adequate weight loss, but it is not acceptable nowadays to have liver failure after any bariatric surgery. We know that we see it in sleeve, We see it in non-anastomosis. We see it in raw OI, and it is published. Okay, we can see it in every type of bariatric surgery. For the sleeve, don't go too tight just to say Dr. Fawal is an excellent surgeon and I lose 100 kilograms. This is not the issue. And same for one anastomosis and for any other procedure. Always put the risk-benefit ratio for the patient and try to abide by the standard of care as much as you can.
Sir, so much thanks. Really, it was definitely one of our best sessions. Sir, any message for our youngsters who are they are doing bariatric surgery? If they face such a situation, what they must do?
A message is a message that I got from my mentor in surgery, Rahmatullah alayhi, Professor Ali Raad, when we started to do the residency. So, primum non nocere. This is the term that he taught us. Primum non nocere, do no harm. Always think how I can do no harm to my patient, to choose what is the best for him, to check more for the indication, for the best technique, for the best follow-up, and then give him my advice and what should be done, and not just to embark on doing surgeries. This is not our aim as I told you, as a wise man, as a bariatric surgeons.
Sir, so much thanks, and we in future also we will need your support, and you are always supportive, sir. So much thanks, my viewers. These sessions are due to your support, and I can see some of our colleagues from India. They are sitting here till this time, and I know now midnight 1 p.m. 1 a.m. there, and also from other countries as well. From Tunis, I can see. From Egypt, I can see. From many countries, I can see here, and also from Bahrain, I can see one of our colleagues is sitting here. So my thanks, sir. Really, it was one of our best session, and my colleague, my viewers, my friends. So next week we will also with another legend of bariatric surgery. We will continue this interview series, revisional bariatric surgery, every Tuesday evening, 10 p.m. Dubai time, till June 2023. So much thanks. If you have any question, you can ask in comments, and Professor is available always. Sir, again, so much thanks, and have a nice time.
Thank you, Amran. Thank you so much.
Thank you, sir.
Good night.
Thank you.